Everybody, it's 4 p.m. Italian time, so it's a time for Food for Veins. As always, we welcome 30 seconds for allowing everybody to join in the platform. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and welcome everybody again to Food for Veins, Veins for Food, a humanitarian not-for-profit educational initiative that always starts with the art and heart of Monica Glowinski, dedicated to all the health professionals who have shown such a good heart during this tough COVID time that is leading also to tough socioeconomic moments, according to the Lancet publication, for which we decided to develop this humanitarian and educational initiative. Nothing would have been possible without the volunteer support of a truly stellar faculty, both in the recorded video lessons and also in these live webinars. And also thanks to all the live attendees of these initiatives who have joined us in this teamwork. I take this chance to deeply thank the previous webinar keynote speakers for their time in this week for answering to the questions we could have not answered live because, of course, of the time. You can find the answers in the educational platform in the Bwin Foundation website. So I encourage you to do the same today while we are talking about sclerotherapy, and ask your questions in the question and answer box in whatever language, and be sure that if not live today, for sure they will be answered during the week. Also today we will deliver CME credits internationally and also nationally. And I take this chance to deeply thank Professor Bradbury for the huge honor of sharing this webinar with him. We will introduce him properly later on. I deeply thank Professor Pauline Raymond Martin-Beau for having taken the role of master in the recorded video lessons, extra educational material you can find inside the platform. And I take this chance also to invite you to enjoy the wonderful educational activity Canadian Society is developing online as well next September, October. It's a huge pleasure for me as an Italian to share these webinars also with key figures from France in the person of Jesnine Mathieu, and together, of course, with my mentor and also, I would say, family member, Lorenzo Tessari. They will wrap up all the concepts in take-home messages form at the end of this webinar, but not before having enjoyed the important opinions and comments from continental expert representatives coming literally from all the continents, and we will introduce them properly one by one later on. Nothing would have been possible without the support, as I said, of the faculty and also of the individual donors and also of the industries who supported this initiative with unrestricted grants. So thank you, AMNO, Balton, Bayer, Medi, Servier, Sigvaris, and Tactile. Thank you to these magnificent 7 companies and to all the ones who have joined this teamwork for Food for Veins. And talking about food, let's hope soon we will be sharing food again in a nice social moment in person. That today would have been beautiful to have in honor of Marina Demeshkova, our friend from Russia, who today is celebrating her birthday. At this point, as always, I pass the mic to the ones I consider colleagues, friends, but first of all, family. So Oscar, the mic is to you.
Dear friends, being here today is my true honor today and pleasure. Through the presentation, you can make any question in any language. Por favor, en habla hispana, pueden hacer sus preguntas en este chat durante la presentación, así que no dejen de consultarnos. Thank you.
Gracias, Oscar. Now we move all the way to California, deeply thanking Professor Chi, because it's always 7 a.m. for him and it's a weekly commitment. So thank you so much for caring so much.
Thank you, everybody. Thank you, all the speakers and our friends and colleagues. Good morning, good afternoon, and good evening. Let's get the show started. 各位朋友，各位同道，大家好。如果今天是我们第4次的视讯会议，如果大家有任何问题，请在我们的 Q&A 箱里，然后问您的问题，我们会尽量的答复。谢谢大家。
Thank you so much. And it's not because it's very early in the morning and he got distracted in the language, but it is because he has been so nice to say to all the Chinese friends who are following us that they can make questions also in Chinese. As you know, at this moment, we always introduce the guest of honor of the webinar, that in this case is coming from the angiology world. The guest of honor is always somebody who is representing a top professional figure related to venous and or lymphatics in an overlapping way. So it can be, for example, professor of nutrition, like we had in the past, public health representative, and in this case, angiology indeed. The guest of honors is Professor Giampiero Vruscio. He is the director of the angiology unit at the University of Padova and also the coordinator of the Department for Functional and Clinical Diagnostics. First of all, he's a friend who many of us knows because he has been involved in our meetings previously. And in this case, we wanted him to be the guest of honors because he set an example for all of us on how to manage at best COVID in this tough time. He really did a splendid job in the University of Padova. So I welcome his 1 minute talk. Giampiero, the mic is on you.
Thanks, Sergio. Thanks, Oscar and Willy, and hello to everyone. For me, your invitation is an honor, but forgive me for my bad English. Padua is not only known for its St. Anthony Basilica, for the presence of Galileo Galilei, for the Giotto Chapel, but its university is among the oldest in the world. Last year, the University of Padua celebrated the 400-year anniversary of the death of Fabrici d'Acquapendente, who first described the venous valves and their functions in the book De Venarum Osteolis, as well as having designed the first anatomical theater in the world that's still perfectly preserved. A pupil of Fabrici d'Acquapendente was William Harvey, who also described here in Padua the physiology of the circulation as it's known today. If we then consider that Realdo Colombo in Padua discovered the lung circulation or the small circulation, we can say that Padua is the capital of circulation. This tradition in Italy has continued over time, and in 2 years, the University of Padua will be 800 years old. So I look forward to welcoming you in Padua. With this hope, I thank you again for the privilege of this invitation, and I wish you a good web session. Grazie a tutti e arrivederci a Padova.
Thank you. Thank you so much, Giampiero. I wish you could receive the clapping of all the ones who are following us, and I'm sure many of them will join you in the beautiful Padua. Now we get to the scientific part finally. And you know that usually we couple the keynote speakers with big artistic figures from music to painting. Now the topic today will be about sclerotherapy, coagulation, and COVID. And for this reason, there won't be any coupling with big artistic figures, just a pianist who is hoping that you will not shoot him because he's just trying to do his best to answer to the questions about what we know about indeed sclerotherapy, coagulation, and COVID. Following the Confucius quote that we should not do to the others what we don't want the others to do to us, meaning that indeed it's quite a challenging topic for which I thought about putting myself at stake and brainstorm with you about what we know. I have no conflicts of interest to declare, while I declare that is pretty interesting the amount of friends and colleagues, starting from our common friend Paolo Valle, for example, reporting the eventual concerns of sclerotherapy, thrombosis, and in particular in this COVID time in which we know that thrombosis is particularly present. Now, my literature search actually goes back to 1992, and it doesn't start with humans, it starts with dogs. And it doesn't focus on the lower limb varicose veins, rather on the esophageal varices. But already then was it demonstrated that STS, even more than polydocanol, was actually prolonging the PT and the APTT, so showing actually an anticoagulant effect. Years later, the brilliant group of Professor Parsi from Australia showed us that actually less is more in this topic, meaning that a lower concentration is actually associated with more coagulation. And indeed, as you can see, high concentration of STS, even more than polidocanol, was associated in the lab with an anticoagulant activity. The same group, 2 years later, showed us also distance-dependent effect on coagulation of sclerosants. As you can see over here, with a higher concentration, as soon as the product exits the needle, you have no clot formation. Then you have a weak clot formation at mid-range concentrations, and then you have clot formations at lower concentrations. Always the Australian group with Connor moved from the lab to the clinic with this very elegant study that is showing us what happens when we are injecting foam 5 centimeters away from the sternofemoral junction, looking at the target vessel, so the GSV in this case, looking at the nearby deep venous system, and looking also at the systemic circulation. Now, the good news is that systematic clotting time is not affected by STS and also by polidocanol, as you can see over here. Angelina Jolie, with her aesthetics over here, is reminding us that this was demonstrated also in 2012 for aesthetic phlebology with the treatment of reticular veins, where you can see that also in this case, APTT and PT was not actually influenced. If you look in the details at the deep veins near the target vessel, so the femoral vein near the GSV that was treated by Connor and colleagues, you see that the PT is not influenced. If you look at the STS, the APTT is actually decreased in this case, as it is the activation time for factor 10, while polidocanol is not showing this decrease in the APTT. If we look at the target vessel, so the GSV in this study, we see again that with STS, we have no variation in PT as for the polidocanol group, while APTT is actually decreased significantly as it is for the time of activation of factor 10, while with polidocanol, just activation of factor 10 is significantly decreased in terms of time. Always in the same investigation, they showed us once again the distance-dependent effect for which at 15 centimeters, there was a significant decrease of factor 10 activation, as it was in a lesser way, in a smaller way at 30 centimeters, while at 45 centimeters, there was a normalization. Always the same brilliant study showed us that the D-dimer was actually significantly elevated following STS and polidocanol after 1 hour and also after 1 week. That leads me to suggest you to consider properly this data when you are, for example, looking at the D-dimer in a DVT evaluation after a sclerotherapy procedure. The clinical consideration is that the coagulation balance has been kept, and indeed, if you look at systemic data, and you will see also this in this investigation, no thromboembolic complications were reported by Connor. A few months ago, the same Australian group of Parsi showed us something really interesting. Sclerosis is different from thrombosis, as the same sclerotherapy names would suggest that I would say. Indeed, it is sclerotherapy. It's not thrombosis therapy. In this study, they showed us with a 6-year follow-up and 9,000 procedure that in reality, the percentage of deep venous occlusion was very low, 2.83%, with a 0.07% cases only of DVTs, with a license to embolize and kill, to say that in a James Bond fashion. And this deep venous sclerosis was actually the major part of the occlusions, with the risk factors like higher volumes and lower concentrations. Interestingly, the deep venous thrombosis group had just higher volumes as a risk factor, a data that is in agreement with the previous publication of Myers that is showing once again that 10 mils was a risk factor for deep venous occlusion. That is in agreement also with Kulkarni, who showed us again the 10 mils as a risk factor for deep venous thrombosis that in this study was reported to be at 1.5%. Back to Parsi investigation, we see that the D-dimer in the deep venous sclerosis group was actually significantly increased, and even more in the deep venous thrombosis group. So that now they are proposing the cutoff value of 0.51 for the D-dimer for deep venous sclerosis and more than 1 for deep venous thrombosis, combining the D-dimer with ultrasound criteria for the management of the post-sclerotherapy management. A similar attitude was shown years before in 2009 by the Japanese group of Takashi Yamaki, combining a preclinical probability test with the ultrasound evaluation, of course, but also with the D-dimer. And as you can see, in this case, the D-dimer cutoff changes with a low preclinical probability having a higher D-dimer value compared to the value that also the Parsi group was proposing. Parsi group from Australia, Watkins from England, the same Professor Tessari showed us with very elegant papers the safety profiles of foam thanks to the inactivation of the same blood toward the sclerosant. So sclerotherapy can surely work and is safe. Let's see if we can make it even safer in this COVID time. Back to Takashi Yamaki, it was demonstrated that multiple injections of less than 0.5 cc are associated with less migration into the deep system. Now, the interesting thing is that there is no significant variation in the superficial thrombophlebitis in this study. We can discuss about that. If we look toward the end of my talk at the high-risk patients in sclerotherapy, we know that they are a relative contraindication for our sclerotherapy act. But it's also true that we have papers like this one on post-thrombotic syndrome patients showing us that with the proper management of proper compression and proper thromboprophylaxis, actually in this kind of population, no DVT or PE was reported. This is in agreement with a very nice study back from 1997 on the dysplominogenemia patients showing thrombin-antithrombin complexes not significantly changing after sclerotherapy, while it was really changing after surgery. So that my personal opinion would be that maybe we want to think twice before doing surgery and sclerotherapy in the same stage in this COVID time. The French group of Amel Desnos showed us in this very beautiful paper what happens with the thrombophilic patients under proper management of thromboprophylaxis, having no DVT or PE reported. So moving to the COVID part of the talk and the importance that has been reported, of course, of proper thromboprophylaxis. We know that coronavirus of COVID is associated with a 9 times higher risk of developing microthrombi at the alveolar capillary circulation with severe endothelial injury. It's my Italian pride leading you to this Italian paper that has been published literally a few minutes ago. It's still to be published, but has been accepted, showing how there is in COVID a switch from type 2 to type 3 hypersensitivity, which means deposit of immunocomplexes in the same vascular wall with a cytokine storm that is actually involving the same cytokines also that we were reporting with our group of research, potentially being fixed by a venous procedure. We know that thrombosis is extremely frequent with COVID, up to 46% of the patients in the general ward had it, up to 79% in the ICU. And we know that D-dimer is a risk factor with an odds ratio up to 5. And 5 is the millions of patients on which the Caprini score has been tested. There is a mic going on, please switch. I have somebody in my speaker. And this Caprini score has been now also stratified for COVID, thanks to the splendid work of Zaplin Russian group with Caprini, suggesting us to give 2 points for asymptomatic COVID, 3 points for symptomatic COVID, and 5 points for symptomatic infection with positive D-dimer. I usually quote Shakira, the singer. Maybe you remember her beautiful song, Whenever, Wherever, whenever I'm talking about sclerotherapy, because sclerotherapy is indeed whenever and wherever. Whatever brand new device we have in our office, at the end, we close the day always doing sclerotherapy. So we do that whenever, we do that wherever. Surely we don't want to do it whatever. We must be aware that we are treating patients with varicose veins, and for this reason, they have already an increased risk of DVT, according to JAMA, up to 5.3. But we also know the Bible, Matthew 7.3, asking ourselves, why do we look at the speck of sawdust in our brother's eye and pay no attention to the plank in our own eye? Because if we really look into the literature, actually potentially we have more thrombosis following endovenous or surgical procedure rather than sclerotherapy. And this is in accordance also with this paper published on Phlebology 2015. So my final take-home messages are, we should always give time to our patients. Maybe it's not easy, but for sure this will allow us to obey to the golden rule of Master Caprini, who is teaching us to never treat the patients as strangers. We should treat them as friends. Like in our friends, we know all the risk factors. Then we should know all the risk factors of our patients so that we will never get the risk of killing a friend. So the suggestion is print the Caprini score, stick it on your office wall and update it with the extra points for COVID. I think that difficulties are always opportunities. So in this case, we can go back to 1995, the paper talking about rurality and the lockdown related to COVID makes me think that if you think about the people living, for example, in rurality, they're kind of locked down as well. So the importance of increasing awareness on venous health. Compression, for example, we know it is recommended by the guidelines for improving the aesthetic results after sclerotherapy. But we know also that compression does much more according to the evidence, and we should mind this fact. But we should also mind the gap, meaning the British GAPS study that just has been published on BMJ, suggesting that compression could not be helpful in elective surgical patients. At the same time, we should also be aware of all the data reported in the document of the Winter meeting in 2019, where we look at the different guidelines from all around the world, talking about homogeneity and all the data we must have in our mind to avoid the risk of comparing oranges with apples, since we are talking about food for veins over here. In conclusion, what should we do, not just for sclerotherapy, but for whatever venous procedure? Just 3 things, in my opinion. A proper risk assessment, remembering that for sure sometimes less is more, but sometimes more is more, meaning that maybe we want to add more to our patients in terms, for example, of compression whenever the risk benefit allows it. And last but not least, indeed, we should do proper sclerotherapy. So the importance of having proper training, performing with proper material sclerotherapy, so to be sure to give the best to our patients, as the world champ of sclerotherapy, Pauline Reymond-Martin Bot, taught us. And you see her here with Christian Ghedina, our world ski champ, together with all the faculty who took part in the Winter 2019 document, and I deeply thank all of them taking this chance for doing that, and taking this chance also for inviting all of you to enter this website of the BWIN Foundation, where you can report, even anonymously if you want, eventually fake news in venous and lymphatics, so that the scientific committee can work on this and together with you, of course, work on a consensus document that we will present during the Expo Dubai in 2022, where I'm sure we will have a nice food moment, and not just for humanitarian purposes like now, but just for being together finally again. And this is the time in which we pass the mic for the scientific round to our friends and colleagues from all around the world in alphabetical order. And it's my deep pleasure in this case to introduce Alejandro González Ochoa from the Mexican Venous Forum. I know that Mexico is undergoing a very tough time, so it's also the chance to send a virtual abrazo, a hug, also to the Tournai Society, also to the Vascular Surgery Society of Mexico, and also to the Academy. Alejandro, the mic is on.
Congratulations. I always enjoy your talks, and I'm going to have to steal some of your slides. 2 quick comments. We have
just one, Alejandro. Choose one, because you have 1 bullet.
Okay.
To shoot.
Although it seems logical to show, to adapt the risk scale for DVT, we should be careful, because I can have a score of 1 in the Giammattei scale and still be a contraindication for sclerotherapy. And I see patients in the private practice with a Caprini score of 5 or 6, and I'm not going to give them low molecular heparin. But my question is, although I don't see any indication for treating patients for high risk of COVID-19 less positive COVID-19, we are going to start seeing recovered patients from COVID-19. So how long should we wait, and how should we treat these patients?
Well, of course, the Caprini score is not the only tool you have, and as always, it's a guide, which doesn't mean that you apply that blindly. So you will customize to your single patients. And we are not talking about doing sclerotherapy to a COVID-positive patients. We are talking about the risk associated with thrombosis. So I would say that, as always, once you are excluding the presence of a DVT, not just with the ultrasound, because we know that the ultrasound is not enough, but with the dimer, for example, then you are totally sure, potentially, according to the data we have, that you should be in a safe range. And that would be my 1 minute answer. And then if you have other ask questions, you can always report them in the question and answer, and for sure they will be replied later on. So now we share the screen once again, because Oscar, it's your time to introduce the second continental representative.
Okay, thank you, Sergio. Let me introduce a wonderful person and professional, Mark Malouf, from the Australia and New Zealand Society of Phlebology. Malouf?
Thank you. Thank you very much indeed. Sergio, along the same lines as Alejandro, you told us about the conflicting information about sclerotherapy and what it does to the coagulation pathway. But we don't exactly know what COVID-19 is doing, apart from making more inflammation and more cytokines and more thrombosis. So, like Alejandro said, if we're faced with a patient for sclerotherapy who says, yes, I've recovered from COVID-19, I'm negative test, no symptoms, and I need my sclerotherapy. What should we do at this point in time? Should we cover them with some anticoagulants for a few days? Should it be a contraindication? Should there be a time limit away from the positive test that we would inject them? How would we do that in the next few weeks, for instance?
That's a brilliant question, but again, I think it's interesting the question is including the topic of sclerotherapy. And it's not including the topic of whatever venous procedure, because I wouldn't feel more comfortable in doing a surgical procedure, according, for example, to the Ikeda paper showing that actually I had a higher antithrombin complex after surgery. So at this point, I think the question is opened up to all venous procedure, and sclerotherapy actually has some major benefits, including, of course, limited contact with the hospital environment, less cytokine potentially compared to others. And again, we will have to customize the prophylactic scheme for all the patients. But again, I think that the real point over here is, what do we want to think about sclerotherapy compared to the other venous procedures and the advantage a minimally invasive act like sclerotherapy has? Are we really thinking that it is going to give more thrombosis or not? Because potentially it's giving less. That would be my message. So if I have to choose between an endovenous procedure or a surgical procedure, in this time, actually, paradoxically, I would prefer to do sclero with all the right measurements of prophylaxis and assessment of risk factors. Yep. And then we move to Willie for flying all the way from Australia. And I'd like to take this chance to deeply thank Mark that is getting the golden medal in friendship for the webinar, because it's midnight for him. So Mark, if you can stay with us, great. If you want to put the pajama on, it's totally understood. If you want to stay with us in pajama, you can do that. So Willie, the mic is for you to introduce the next speaker.
Yeah, so it's my honor to introduce Dr. Nicolas Lumi from French Society of Phlebology as our next panelist.
Nicolas?
Yes, Sergio, thank you for your invitation. Thank you for your talk. Very clear, very interesting. You explain well the risk and benefit of sclerotherapy during COVID. But in a future pandemic at COVID, if you are the Minister of Italian Health, will you allow the practice of sclerotherapy?
Very bright question, very artistic and French. So the question is if I would allow that during COVID time in a COVID patient, because the answer is absolutely no, unless it falls into one of the categories that, for example, we are reporting the VELTAS score with the UAP, or in the categories for indicating emergent treatment on varicose veins, which is basically inexisting, maybe bleeding varices if there are like a major bleeding, but that would be the only moment. And again, in case of a bleeding varices, you would have the advantage of having a minimally invasive, not requiring operating room procedure. So in that very remote possibility of having to treat somebody and in the impossible possibility of being the Minister of Health, I would say that just if there is a bleeding varices that is in some sort of way threatening the patient. And again, you can make all the other questions later on, sorry, but we have to keep the time going. And it's actually my deep pleasure now to welcome the last question on the way to North America. And it's a silver medal because it's 7 a.m. for her. So just Oceania won with midnight for the current president of the Canadian Society of Phlebology, Mandy Wong, and we really wanted her over here also because she has been highly involved in the UAP contraindication to sclerotherapy document with a brilliant job. So Mandy, shoot me.
Okay, thanks for tackling such a difficult subject. We've seen reports that the incidence of individuals with COVID, but that are asymptomatic, is in the range of 20 to 30% in the population. So it's likely that we'll be seeing some of these individuals presenting for venous procedures who haven't been tested. In my practice, I do obtain a Caprini score before treating my patients and consider on a case-by-case basis the need for anticoagulation. But in this day, for cases where the Caprini score is borderline for the need to anticoagulate, should we be more liberal with anticoagulation if there's no contraindications?
Another very bright question. So I would say that for sure we have multiple tools we can use. In this stage, I think we have a weapon we don't use so much. For example, in surodexide or heparinoid substances that can eventually help us as well in the borderline cases for coagulation management. Of course, we can be more liberal, I would say. For example, I would like to brainstorm if we should automatically add 2 points in the Caprini score in this stage, considering that Caprini was suggesting those 2 points for asymptomatic COVID positive. So suppose that everybody is positive, but it would welcome also, again, anticoagulant help from substances like, for example, the ones I was mentioning, or for example, a proper compression in a more liberal indication. Liberal does not mean radical, and that is the thing. So of course, we always have to be sure we are not harming the patient. So we are, thank you so much, Mandy. We are now moving to the open question time, and I will ask Professor Chi to be the moderator that I usually do, but I don't want to have the bias of choosing my own questions. So these questions are coming from all the audience. And again, we will welcome all the questions in whatever language, and we will answer to all of them during the week. Also, thanks to Professor Bradbury that I will introduce in a few minutes.
Yes, I think we have a couple interesting questions. I think that will give us enough time for Sergio to answer those. First, we have a question from Professor Rashad Bashara. The question is, what is your key recommendation to reduce post-sclerotherapy thrombophlebitis?
In this specific time or in general? Like, well, let's say that the first thing I would recommend in this time is always to remember to avoid, for example, aesthetic sclerotherapy if we are having the minimum supposition of an eventual thrombotic process. And in order to reduce the risk of this thrombotic appearance, I would suggest to remember that maybe sometimes less is more, as I was saying before, meaning that we don't want to create thrombosis, we want to create sclerosis. So it's fundamental that we use the right concentrations. Sometimes the dilution of the product can actually activate thrombosis rather than sclerosis. So my suggestion would be sure that we are performing sclerotherapy in the correct manner, with the correct material, with the correct dosages, because we have demonstrated with the data that in proper hands, the risk is actually low. And this is, of course, empirical, but I truly trust compression as an anti-inflammatory mechanism also. So I would be more generous with compression in this time.
So our next question comes from a good friend, Dr. Neil Kalani. After symptomatically recovering from COVID, is there data to demonstrate the risk of VTE returns to baseline or when D-dimer returns to normal range?
I'm actually not aware of this, of course, in a significant term of time, because it's extremely recent. And I think this opens the questions to the D-dimer evaluation in these patients. Because as we have seen, the D-dimer, of course, correlate with the condition, but at the same time is influenced by the same sclerotherapy act. So I would really caution colleagues to rely so much on the D-dimer. I think we never talk so much about is how long we want to go with the anticoagulation, because it has been shown, for example, that a short time can be good, but it has also been shown that we have a significant number of non-targeted thromboses in sclerotherapy. Because the Lobastov group that few months ago published a very elegant paper from Russia once again, showing that up to 23% of sclerotherapy acts have a sclerosis or a thrombosis. It would be nice to see that, mainly in the GSV or in the middle cuff they were seeing. So I think that at this time, the D-dimer evaluation could be quite tricky, up to also 6 weeks in terms of thromboprophylaxis.
Sergio?
I think that's it.
Sergio?
Oh, yeah, Oscar.
Roberto Forminasha said or asked about the foam. Would you, what is your opinion, Sergio, about the foam in this little vessel?
Can you repeat, Oscar?
Foam, realized foam in the little vessels. What is your opinion?
Oh. That's a huge question mark I have, because if you think about the big vessels, in reality, it's easier to have dilution. And indeed, it has been published recently, just a few days ago, I think, that long catheter is associated with less thrombosis in a review. Which could be explained, and I'm sure Attilio Cavezzi will love this, with the fact that you have less dilution, you have the compression of the vessel. And if you have less dilution, you don't get the risk of going low with the concentration. So if we believe in this mechanism of having low concentration and higher coagulation, then that could be an explanation. On the other side, empirically, I've always had the feeling that the real complications we get are when we are doing aesthetic sclerotherapy in an improper way, because the surface, the total surface of the endothelium bed is wider. So I think this is really not food for veins, but food for thought, because empirically you have the feeling that it is more dangerous to go on the reticular, but theoretically it looks like we have more risk of thrombosis if we dilute the sclerosant in the bigger vessels.
Do we have a question? Do we have time for one more question? Or
yes, also because I loved that you muted Oscar.
All right, so our next question is sclerotherapy safe in cases with previously treated and cured DVT? When to do and when not to do?
Another very good question. Again, I think we should really rely, and that's my, of course, personal opinion, on a proper evaluation, not just of the ultrasound, but also of the D-dimer. And honestly, I would rely on that before starting whatever major sclerotherapy procedure. At the same time, we have seen with the Parsi paper just of this 2020, that in reality, we are talking about sclerosis if the sclerotherapy act has been done properly. So again, I would consider that usually at least 6 weeks should be considered from the time we are 100% sure that all is fine, just to say on the extreme safe side. But in reality, I have the feeling we could be also shorter in time. And right. I think we will welcome the last question, because then we have to move to Professor Bradbury.
Yeah, Sergio, before the question, I want to just make a comment because there was some talk about the COVID. These COVID patients, even after they get discharged from the hospital, based on what we know currently, that they're still at elevated thrombotic risk, even 4 to 6 weeks after discharge. So that is something for us to keep in mind when we take care of these patients. So with that being said, the last question that Sergio will have is, in COVID-19 symptomatic patient with 3 times the D-dimer level, do we have a consensus on potential doubling the dose of prophylactic anticoagulation regimen?
The answer is, if we talk about consensus, that's a big word. If you're talking about indications, if I'm not mistaken, the same American Venous Forum released a document suggesting that we had an increased value of the dimer, and there are like some ones following, for example, the 3 times, and some other are using like the 3 milligrams per liter. In that case, they are considering the potential doubling of the dose, but I wouldn't say this is it's an internal consensus, I'd say. So again, I will reply to all the questions during the week. I deeply thank all the ones who have made questions, and I suggest you to keep on doing that for the next part of the webinar, because it's 4:40, and it's a huge pleasure for me to introduce Professor Bradbury. And this is the time in which we go back to the big stars of music as a metaphor, because the ones who are close friends of Andrew knows that he is an excellent drummer, and he is from Birmingham University in the UK. So I thought that Roger Taylor, the drummers of the Queen, is the best metaphor for introducing a person who actually needs no introduction. He has a huge leading figure in the venous and also arterial ward. The numbers of trials and major investigations is involved in are really spectacular. And I also always think that it's not just where we are going, but also with whom we are going somewhere. And so the family is always the best ID. And I have to say that I have the pleasure to meet the family, and is really a very nice ID. So Andrew will talk to us about sclerotherapy safety and efficacy with an evidence-based update. So Andrew, I will now pass the mic and also the screen to you for sharing your presentation. Thank you so much for the honor. Andrew, can you hear us and share your screen?
Is that working?
Yes, this is perfect.
Okay, great. Well, thank you very much, Sergio. And this is an amazing thing that you've managed to organize. I'm sure there's lots of people helping you, but I think it's just remarkable what you've achieved, and very impressed. And it's lovely to see so many friends and colleagues from around the world. The technology is extraordinary. I enjoyed your talk very much, and I enjoyed listening to Professor Busio as well, our guest of honor, speaker. So Sergio has asked me to talk about ultrasound-guided foam sclerotherapy, which is a bit of a passion of mine, as you probably know. And he's asked me to talk about clinical performance and safety. Now let's just see if I can... Good, it is working. Okay, so it's a huge topic, as we all know, and I've only got 15 minutes, so I'm going to have to be fairly selective with the data that I share with you. In terms of clinical performance, what I thought I would do is just briefly review the randomized controlled trial evidence for foam sclerotherapy, which has mainly been in comparison with endothermal ablation. And then with regard to safety, I thought I would show you some data from the FibroVein post-authorization safety study, the PASS study, that we've been collecting over the last 5 years, and we've now finished that data collection. I'm going to show you some data based on 10,300 foam sclerotherapy cases. So back in 2015, we looked at the randomized controlled trials, and this was led by one of my colleagues, Hugh Davis, who did the lion's share of the work. And at that stage, these trials had been published. There were 4 trials. The Danish trial had been published twice, but it's the same patients. Now, the thing is, there's only 467 patients in all of these trials randomized to foam sclerotherapy. And although that seems like a reasonably large number of patients, when one thinks of the tens, probably hundreds of thousands of people that have sclerotherapy every year around the world, it is a very tiny sample size. Anyway, to cut a fairly long story short, what we concluded back in 2015, 2016 is that there was no significant difference in clinically important outcomes between foam sclerotherapy and endothermal ablation. Arguably, the best trial, one of the largest trial, is the Rasmussen trial. And this is quite an interesting set of data, because what it shows is, although objectively you get more recanalization with foam sclerotherapy, and there were more reinterventions with foam sclerotherapy. In terms of patient-reported outcomes, the 4 modalities that they compared were really very similar. So in the bottom left-hand side, you see the VCSS, and the bottom right-hand side, you see quality of life, Aberdeen varicose vein severity score. So what Lars Rasmussen and his colleagues concluded was that all treatment modalities were efficacious and resulted in a similar improvement in patient-reported outcomes, but there was more recanalization and more reintervention seen in the foam sclerotherapy group. Now, quite a lot has changed since 2015, 2016, and it's not just COVID. We've come a long way in venous treatments in 5 years. It's a very rapidly developing field of work, which is why it's such an interesting specialty to be involved in. And so there have been some more randomized data made available over that period of time. So this is the RCT data from Netherlands and Belgium. There were 2 publications here, one in the JVS in 2013 and one in the BJS in 2015, presenting 1 and 5-year data. And what the authors concluded was that laser ablation was increasingly more effective than foam sclerotherapy in terms of anatomic success, but also in terms of clinical success as time went on. But the foam sclerotherapy technique is incompletely described and probably suboptimal by comparison with what many of us would consider standard of care now. For example, they used a single injection point, generally low volumes of weak sclerosant in low concentrations, and only the trunk vein was treated. There was no treatment of tributaries or varices. So foam sclerotherapy enthusiasts might say that predictably they found high early anatomic and clinical failure rates with foam sclerotherapy that perhaps unsurprisingly got worse over time. The other randomized trial comes from Finland, again 2 publications a couple of years apart, presenting 1 and 5-year data. One could say really the same things about this RCT as with the previous one. The foam sclerotherapy technique is not completely described and probably suffers from some of the shortfalls of the previous Netherlands and Belgian trial. And again, they found high early anatomic and clinical failure that again got worse over time. This is the CLASS trial from Julie Brittenden and colleagues here in the UK. This was published, 5-year data was published in the New England Journal of Medicine. I'm sure you've seen this. There was no radiofrequency arm, which I think is unfortunate. And I think very surprisingly, there was no foam sclerotherapy protocol. And if you look at the outcomes, we find that with the foam group, only 54% of the great saphenous veins were closed at 6 weeks after treatment. And it was only 18% with the small saphenous veins. Now, I think many of us would say that that's an unacceptably high failure rate. And it makes it very difficult to compare long-term outcomes between different modalities when the inference is that one of the procedures has probably not been performed at a standard of care that we would now consider reasonable around the world. But it's not all bad news for foam sclerotherapy. This is the EVERA trial, which I was involved in, led by Alan Davis from Imperial College in London. And again, I'm sure this will be familiar to you, published in the New England Journal of Medicine in April of 2018. And what it shows is what we all thought we knew anyway, but we've kind of proved it in a randomized controlled trial, that early ablation of superficial venous reflux in patients with venous ulceration speeds up healing when compared with compression alone. And what's interesting is in this trial, about 2/3 of the patients were treated with foam sclerotherapy. So you can see that foam sclerotherapy is very popular in the UK, particularly in this patient group. And in fact, in around 50% of the patients, they had foam sclerotherapy only. So I think this does show that foam sclerotherapy can be anatomically and clinically effective if used in the correct way. So that's a bit on clinical performance. What about safety? Well, as I said, I'm going to show you data from our past study. I'd like to acknowledge the enormous contribution of my colleagues, and particularly of Hugh Davis, my colleague, who's really organized it primarily from within our department. And I'd also like to recognize the support of STD Pharmaceuticals, now Merit Medical. So over a 5-year period, we collected data on patients undergoing foam sclerotherapy procedures from 34 centers from UK and Europe. These were public hospitals, but also private clinics. They were patients over 18, not pregnant, not breastfeeding. The median age was 55, and around 2/3 of the patients were female, and the median BMI was 23. We've collected data on 10,300 treatments. In almost a half of the patients, the treatments, the patients received foam sclerotherapy only, and in the other half, it was used in combination with other modalities, mainly various forms of endothermal ablation. And you can see the SEEP clinical grade on the right-hand side. Perhaps unsurprisingly, most patients were SEEP clinical grade 2, and only about 4% of the patients had ulcers. So we have collected an enormous amount of data, so I can only share with you a few highlights today. But these are the adverse events and the serious adverse events. So if you add those all together, 45 patients had an adverse or a serious adverse event, and this was in the treatment of 56 legs. So that's 0.45% of the patients. There were 17 patients who had a headache, migraine without visual disturbance. There were 9 patients who had migraine, headache with a visual disturbance. There were 12 patients who had a visual disturbance or scotoma without headache. There were 2 vasovagal episodes. All of these, of course, were transient. So now if we get on to the serious adverse events, there was 1 anaphylaxis. There was 1 transient ischemic attack. There's 1 patient who suffered temporary weakness, and there were 2 patients who had strokes. And I'll tell you a little bit about these patients in a moment if I have the luxury of time to do so. So you can see that the incidence of SAEs is extraordinarily low, and in fact there was only 1 person who had a permanent effect from this, giving a permanent SAE, a neurological SAE of 0.0097%, so extremely low. Am I okay, time, Sergio?
Absolutely.
Okay.
I'm not going to stop Roger Taylor.
How much longer do I have, Sergio, roughly?
You have time, other 4 or 5 minutes max.
Perfect. Okay. So I thought you might find it interesting if I gave you a little vignette about the 5 patients who had these serious adverse events. So there was 1 anaphylaxis, that's 1 in 10,000, which is roughly, I think, what we're taught at medical school about these things, about 1 in 10,000 anaphylaxis. So he was a 47-year-old gentleman, entirely fit and well, no significant past medical history. Interestingly, he had a foam sclerotherapy treatment on the other leg 8 years previously without any difficulty at all, and had a good result from that. He had a very standard foam treatment of his GSV using a relatively small amount of 3% STS foam. But 2 minutes after the treatment, and this actually occurred in my hospital, one of my colleagues did this, it wasn't my patient, but it was in my own hospital. He developed breathing problems and actually had to be intubated. The crash trolley was called and he was intubated. He was treated with standard anti-anaphylaxis supportive care and drugs. And after 6 hours, the sedation was switched off and he was extubated. And he actually woke up at that point very promptly with no adverse effects at all, wondering what had happened. And he was discharged the following day. So very scary. And I guess we just reminds us all that we need to have these kind of resuscitation facilities in our clinics, because one day it may happen. And if you're not prepared for it, then unfortunately, the outcome could be extremely unfortunate. So the TIA was an 82-year-old lady. She had a history of transient ischemic attacks. Again, she had a very standard foam treatment, which at the time was unremarkable. 8 to 12 hours later, when she'd got back home, she developed numbness and weakness in her left hand. She went to hospital. the weakness resolved very quickly within a few hours. And as far as I know, she's had no other problems since. This is the case of weakness. As a 32-year-old lady, again, fit and well, a history of headaches, but not of classical migraine. Again, a fairly standard GSV treatment with a very small volume of STS foam. But immediately after the treatment, she complained to the doctors of some right arm weakness. There was no headache, there was no visual symptoms, and no other neurology. And this completely resolved in the next 10 to 15 minutes. The treating team thought that she might be anxiety related. Apparently, she was hyperventilating, and so that is, I suppose, a possible explanation. But it got better in 10 or 15 minutes, and she went off home without any adverse impact. So these are the two strokes. So stroke one is a 55-year-old man with a history of hypertension and hypercholesterolemia. He had, again, a fairly standard foam sclerotherapy treatment, absolutely no problems on the day. But 20 days later, he got back in touch with the treating team to say that he had developed weakness in his left arm. This had come on 20 days after the treatment. He had a CTA, which showed a right internal capsular infarct. He was admitted. He made a full recovery over a couple of days and was discharged after 5 days on dual antiplatelet therapy. So this is stroke number two. A 70-year-old lady with no significant past medical history, had foam sclerotherapy with, I suppose, quite a large volume of foam, but only 1%, quite concentrated, though, a 1-to-2 ratio. That was fine, but as the stocking was applied at the end of the procedure, she developed left-sided weakness, particularly of her arm, and a facial droop. She had an emergency CT, which showed a possible air embolus in the right middle cerebral artery. She was given supportive care. She was also treated with hyperbaric oxygen, and she got better very quickly, but she was left with some minor sensation loss in the left shoulder and face. And this is the only case where there has been some permanent sequelae of the serious adverse event. So in conclusion, Mr. Chairman, ladies and gentlemen, I think we can say with some confidence that all endovenous treatments, including foam sclerotherapy, are extremely safe, obviously if done competently in the right patients, and associated with a rapid return to normal activities and lead to clinical improvement in our patients. I think we've all been able to see that. Although we have some concerns about COVID, we probably shouldn't forget old-fashioned surgery completely. But even with the best of technique with foam sclerotherapy, there probably is a higher recanalization rate than we see, for example, after radiofrequency ablation. The question is, does it matter? And in our own data with 5 to 8 year follow-up, we see quite a lot of asymptomatic reflux, which doesn't seem to impact upon the patient's satisfaction with the treatment they have had. You could argue that endothermal ablation of truncal reflux only is an incomplete treatment, whereas foam is more complete because we treat the trunks, the varices, and all the major tributaries, or at least we do in my clinics. Foam is extremely versatile, probably the most versatile modality we have. It's certainly the cheapest, but the Achilles heel of foam sclerotherapy is that it is, I think, we'd all agree, the most highly operator dependent. And if you have suboptimal technique, you're going to get suboptimal results. And with respect to colleagues who have done the RCTs, I think we do see some of that in the RCTs that have been published. Do we do more randomized controlled trials with using different types of foam sclerotherapy, testing different techniques against endothermal ablation and other modalities? Well, I think yes, we could always do with more data. So again, thank you very much. It's a real pleasure and a privilege to be able to have this opportunity to speak to you all. And again, thank you very much, Sergio, for organizing it. Thank you.
Thank you so much, Andrew. I ask Khaled to allow me to share the screen. Meanwhile, I will deeply thank also Oscar and Willie for having made all of this possible together with all the team. We now move to the scientific word round. Andrew, I hope you could hear. We have more than 1,000 people clapping you in this moment, and I will give you the final number tomorrow. So it's a real queen concert.
It is very strange just speaking at a computer screen.
It is, but
we'll all get used to it, I guess.
That's the sad part, but it would be like almost a Queen concert for you as Roger Taylor.
Almost.
Yeah, almost, of course. But let's now fly to North America with the representative from that continent. It's my deep honor and pleasure to introduce Dr. Janna Bentley, immediate past president of the Canadian Society of Phlebology. So Janna, if you can make your question to Professor Bradbury.
Thank you very much, Dr. Bradbury. Excellent talk. I wanted to ask about hyperpigmentation. It's a frustrating, common complication from sclerotherapy. What do you think is the mechanism involved in its formation? Like, is it migration of melanin? Is it hemosiderin deposition? And how do you mitigate this?
I think in terms of the pathology, it's a bit outside of my area of expertise, but I think it's a bit of both. I say to the patients that their leg has gone rusty, and they seem to understand that, but whether that's scientifically correct or not, I think you have to tell the patients it could happen. It may happen. It happens in quite a lot of patients, and I think you have to tell them it will go away. And I have to say, I mean, I've been doing foam sclerotherapy now for about almost exactly 20 years, and it was a great concern of mine right at the beginning. But I actually say, I think if you have a good relationship with your patients and you're honest with them and you have good technique, you can mitigate the fallout from that. And I have to say, I have not had a lot of patients expressing dissatisfaction and unhappiness because of hyperpigmentation. But I think there's quite a lot in the technique that you can do. It's not time to discuss that this afternoon, but I think, yeah, as Sergio says, good technique is everything.
Thank you so much, Andrew. Now we fly all the way to Asia. Oscar can introduce the continental representative.
Okay, let me introduce my colleague of the UAP, Professor Malay Patel, who has traveled to the world of phlebology. Malay?
Khaled, do we have Malay?
Hi, Andrew.
Hi, Malay. I can't see you, but it must be dark where you are.
Yeah, well, it's dark, and I had to drive out to get my good signals because where I live, signals are not good. But I have a comment first, and as you said, I think your sclerotherapy is an art that is waiting for its science, and that's where I think we all are trying to gain more ground. And my question to you, Andrew, is what is your single advice to those who are still wondering about the efficacy and safety of ultrasound guided foam sclerotherapy? So what's your just single advice?
I think it's all about technique. That's the thing that you can teach almost anyone to do an RFA catheter procedure, but I think to do good foam sclerotherapy in a very wide range of patients takes years, and I'm sure I'm better at it. Although I've been doing it for 20 years, I'm sure I'm better. Well, I'd like to think I'm better at it now than I was 5 years ago. I think go to people who are experienced and learn from them. Go to courses. It's all about getting training and building confidence gradually. Yeah.
Thank you so much, Andrew. Now we fly all the way to Russia, and we have Willie introducing the continental expert representative. Willie?
Now we have a good friend of EWIN, Dmitry Rozovsky from the College of Phlebology in Russia.
Dmitry?
Hello, dear colleagues. My question will be related to the skin necrotic sequela of sclerotherapy. Historically, state medicine in the Soviet Union didn't consider sclerotherapy as an acceptable method of treating varicose veins. This procedure was considered as either dangerous or ineffective. Perhaps it was, with then existing sclerosing agent. Yet we didn't have such a close relationship as now with the regard of world phlebology. Foam sclerotherapy didn't succeed in gaining popularity as it was almost immediately replaced for saphenous veins by a more marketing attractive laser thermal ablation. Inherited from Soviet traditions, today's insurance medicine still doesn't cover sclerotherapy as part of mandatory basic insurance for citizens. Given these national characteristics, we are mostly worried by skin complications of sclerotherapy of the reticular veins. Professor Bradbury, do you share the position based on the experience of individual experts and on some experimental animal studies that more viscous sclerosants give a relatively low percentage of complications such as skin necrosis?
Thanks, Dimitri. I don't really know the answer to that question. I have to be honest. What I would say is that I very rarely, if ever, use foam for the treatment of reticular veins. For telangiectasia. I use liquid, very dilute liquid sclerosant. I do occasionally use foam for large reticular veins, but again, I mostly reserve foam sclerotherapy for truncal and tributary reflux. We've talked a bit about hyperpigmentation. I have to say that I've only had one ulcer after foam sclerotherapy, and I remember it very clearly because the patient haunted me for about 2 years and kept on coming back and getting cross with me in the clinic. So I remember it very, very clearly. I don't know what I did wrong that day, but she got a rather nasty ulcer. It healed in the end, but it took a while. But I think foam sclerotherapy is actually very safe in terms of skin necrosis, and it's really not something that I've personally come across.
Thank you so much, Andrew. And now it's my pleasure to fly all the way to Latin America for somebody that is representing varicose veins, basically a combination of genetic factors and of environmental factors, because indeed Carlos is the son of Roberto, and we know he is a great phlebotomist, as Carlo is with these acquired factors. So Carlos, the mic is on you.
Hi, everybody. Thank you for your great intro. I want to ask to Professor Bradbury, you show us that sclerotherapy is safe and effective, but let's suppose that you have in your own body varicose veins and saphenous vein reflux. What is the limit? What do you think foam is enough to treat your varicose veins and the saphenous reflux? Will you choose it to treat your own legs?
Thanks, Carlos. I think the question is, would I have foam sclerotherapy for my own veins?
Yes, of course.
Yes.
For the first option.
Yes. Well, I can declare that I don't have venous reflux yet, so, but I'm sure it'll come along. Yes, I would. I think I would treat myself as I would treat my patients. And I've treated quite a lot of friends and colleagues, and I've treated them in the same way. As yes, I would. I wouldn't have any concerns about having. I would choose very carefully who did it for me. I wouldn't try to do it myself on my own leg, but I would choose very carefully who I chose.
Thank you.
If it is of any consolation, since nobody is listening to us apart more than 1,000 people, I proposed to treat Oscar Bottini, and he didn't trust me. So he's waiting for learning by himself how to inject himself, he told me once.
Well, I'm happy to go to Argentina if that's
if he trusts you more than me, for sure. But I think he trusts only Professor Bottini at the end. But jokes aside, we move forward now with the open questions. So whatever question is welcome in whatever language, and indeed the ones that is getting more likes is in Spanish. So Oscar, make sure that I'm not saying something stupid. What I'm reading here in Spanish is from Luis Emilio Bronzi, and he's asking us, Andrew, if we would recommend routine prophylaxis, considering the number of false negative, or because of the lack of availability of testing. Would you welcome routine prophylaxis? Personally, my answer is no, but I think I will give 2 extra points to everybody in the Caprini score because of the potential symptomatic positive. And that would be my part. And your point of view on this?
So this is the question about prophylaxis for DVT in foam.
Yes.
Yes. Well, in 2010, we presented, we published a paper in the Journal of Vascular Surgery about 1,000 people having foam, and we got them all back for a duplex scan about 4 to 6 weeks afterwards, and the incidence of DVT was extraordinarily low. I think it was 5 or 6. because like hyperpigmentation, DVT was the thing that really concerned me at the beginning. And I have to say, as a surgeon at the beginning, I did not expect foam sclerotherapy to work, but I was very wrong. It does. So I rarely, if ever, use prophylaxis. If I have an elderly patient with a leg ulcer, I might give them a few doses of low molecular weight heparin. But of the thousands and thousands of people I've treated, it would be a tiny proportion of people that I've given any VTE prophylaxis to at all. And to be honest, we haven't seen a symptomatic DVT for, well, 5 to 10 years.
And since one of the beliefs is also that anticoagulants could diminish the effect of sclerosis, and in reality there are papers like the one of Emil Desnos is showing that despite they were all anticoagulated, there was no significant variation in the recurrence rate. Would you say as an expert that anticoagulants are affecting in some sort of way the performance of the sclerotherapeutic act? Because in my opinion is not.
I think that I don't think we really know. What I would say, I treat a lot of, quite a lot of the patients we treat are on anticoagulation, so on warfarin or rivaroxaban or something else, and I just go ahead and treat them. I don't stop it. And anecdotally, I haven't found sclerotherapy less effective in those patients. I mean, it's an anecdotal impression, but I think it works. It seems to work. I remember I've treated people with mechanical heart valves who with an INR of 3 to 4, and it seems to work on them. So
that's great.
I would say no.
So now we fly all the way to Egypt for the Cleopatra of phlebology. So Wasila Taha, is there any anatomical aspect, Andrew, that you would consider as a potential limitation for foam sclerotherapy?
Yeah, so in my practice in the public hospital and in the private sector, if someone has a large 7-8 millimeter long, straight, great saphenous vein, especially if they have bilateral disease, then I will offer them radiofrequency ablation. In the private sector, it's a little bit more difficult because it's a lot more expensive. But in the public hospital, I would do RFA. It's not that I just do foam. We also do endothermal ablation as well. Yeah. Okay.
Now we go back to Latin America with Hugo Navas. Do you think it's safe to do sclerotherapy on lupus or other collagenopathy patients? If yes, do you recommend thromboprophylaxis? I would reply to this again with the paper of Emil Desnos, who was looking at all the different thrombophilia patients and classifying also all the different thrombophilia. So I would recommend to Hugo to have a look at that paper. That was pretty interesting. I have, correct me if I'm wrong, Andrew, I'm not aware of the publications on patients not anticoagulating with this thrombophilic situation, so we cannot really know for sure the answer, but that is mine. So I will pass the mic to you.
I just don't think we know. People in the UK, about 5% of people being of Northern European heritage will have factor V Leiden, but on its own, it's a pretty weak risk factor. We don't screen for it. I think if you find someone who's got from, one of the more serious thrombophilias, you'll have a family history and all that kind of thing. And I think I would think very carefully about treating people in that category. But the numbers of patients I've seen that fall into that category is extremely small, and we don't test routinely. So I just don't think we know.
Okay, and the last one, we go all the way to North America. Our previous keynote speaker, Professor Khilnani, is asking you regarding the past study. Was the saphenous vein the target in all cases? What was the average volume used with the range?
We do have all that data, but I don't, and I can share it with you. We're hoping to go to publication quite soon. We've got a lot of data on how the procedures were done, but I'm afraid
there is a cutting microphone. There are some connection issues. We will have some connection issues in this one. And then we will move to the last one with, again, Wasila Taha. Does using CO2 instead of room air, forming smaller size of bubbles, could be safer in minimizing the adverse effects? Actually, for what I know from the literature, the only data was published on this was that there was a better occlusion rate, but no significant difference in thrombosis. That would be my answer. What would be your answer?
So I can't give you the exact figure, but it was a relatively quite a small proportion of the cases that were done with CO2. The vast majority of the 10,000 cases were done with air. So we don't really, and there's no obvious difference between the patients who were treated with room air and CO2, but the numbers of CO2 cases was very low. So statistically speaking, it's a difficult question.
Yeah, and I think it was European Journal of Vascular Surgery 2011, the one that was mentioning. So Wasila, maybe you can find some extra topic there on this. So now it's time, and thank you again so much, Andrew, for having served in this session. That's been really phenomenal and an honor. And we have now the comments from the honorary chairs. So the idea is that these huge experts coming from huge schools like the French school, the Canadian schools, and the Italian schools are wrapping up the concept for us, giving in less than 5 minutes each their take-home messages. So Matthew, this is the time in which you take the mic, and it's my pleasure to introduce Matthew Jesnen, President of the French Society of Phlebology.
Thank you very much. I've made some notes that I'm going to read to you. First of all, I would like to thank you, Sergio Giannichini, for this initiative that brings us all together today. What a big opportunity to be able, with the technological means at our disposal, to communicate at the same time all over the planet. I would also like to thank you for giving me the opportunity to express myself on this subject, sclerotherapy, which I practice every day. I'm not going back to over the story of this pandemic, which is still to present among many of our friends for whom we are thinking today. The physiopathological mechanism initially evoked was an inflammatory state. Since then, the macrocirculatory damage at the venous and arterial level appears. All specialties have noted very significant delays in the management of non-COVID patients. Now, the objective is therefore to put itself in a position to respond again to demands for care. To do this, it's essential to reassure the population which has been shocked by this pandemic. With regard to chronic venous disease, all these problems arise on the one hand in view of the inevitable evolution of the disease, but also in view of the risk of thrombosis of some treatments that may be implemented to treat it. These two presentations we have just heard were very good and excellent and respond to this problem concerning sclerotherapy. The highlights of Sergio's presentation include the fact that the level of D-dimer will also increase the day following sclerotherapy, as demonstrated by David Connor, which can generate bias when looking for venous thrombosis. The recent publication of Kurosh-Parsi also shows that there is a difference between deep venous occlusion following sclerotherapy and deep venous thrombosis, and the treatment of the former is not necessary. The D-dimer and the ultrasound aspect can also help the practitioner to differentiate the two. It should also be remembered that large volumes of sclerosing foam should not be used, generally not exceed 10 milliliters, and multiple injection sites should be used. Deep vein thrombosis is considered as an uncommon complication of foam sclerotherapy. In patients of a risk of thrombosis, prophylactic anticoagulation can ensure patient safety, as shown by Claudine Amel-Desnos. We must remain vigilant, and the use of the Kraepelin score could allow us to stratify patients and thus increase the safety of our actions, particularly by including the traumatic risk linked to COVID, and thus be able to better apprehend the risk, and thus only treat patients with benefit-risk balance in favor of the benefits. Concerning sclerotherapy in France, it has been proposed by our Society of Vascular Medicine to carry out a self-questionnaire for each patient in search of symptoms of COVID or contact with a sick subject during the 50 days preceding the procedure. Patients are just categorized as having a strong, intermediate, or negative suspicion. Andrew Bradbury showed us that the literature on foam sclerotherapy remains heterogeneous, with the protocols used in these studies are either technically or insufficient or unexplained. What is important is in practice is to understand that sclerosis remains a safe and effective technique. The recanalization rate remains higher, but shouldn't we also take into account the vein diameters in order to adapt our choice of treatment techniques? At the French, to finish, at the French of Society of Phlebology with my colleague and General Secretary, Dr. Nicolas Neom, we have set up an application to evaluate with each practitioner in France the impact of their patient on postponing endovenous thermal ablation procedures. Of course, the same question arises for the postponement of sclerotherapy caused by the pandemic on the state of health of our patients. It seemed much more complicated to us to put such an evaluation in place, but it might be worth looking into it. To finish, the pandemic remains active. Today's webinar proposed by Sergio Gianneschini is an opportunity for all. This space for discussion and reflection, in my opinion, is an opportunity that is offered to us in these troubled times. Let us continue to reflect, to update, and to share. Thank you.
Thank you so much, Matthew Josnen. And now we fly on the way to Canada with Pauline Rimond-Martimbault, who needs no introduction. She's the queen of sclerotherapy, as we all know. Pauline. Unmute yourself. Unmute yourself. Great.
Okay, great. Thank you, Sergio, and congratulations to you and Andrew for such excellent presentations. Thank you, Sergio, Willie, and Oscar for putting on wonderful, exceptional webinars. Now, in the 90s, I conducted an in vivo study on activation of blood coagulation after sclerotherapy with sodium iodine iodide. And I have not found any fibrinolysis at day 7 and day 14. I have been doing ultrasound imaging, venous imaging since 1984. And I did correlate the finding of the non-elevation of D-dimer with the images with the ultrasound and did not see any DVT. I want to be humble, but I have to tell you that I'm proud to say that I received the Jobs Research Award for this study, which I believe it means that this is an important topic. Now, since then, as Sergio so brilliantly mentioned, there has been a great, probably better investigations done by Parsi, Connor, Hamel Desnas, and also Ikeda and Goldman. And they have demonstrated that STS and polidocanol in vitro and in vivo may have an effect on some coagulation markers, but with none or very minimal fibrin degradation. And in all studies, we can say that DVT was very rare. Now, an early elevation of D-dimer at day 1 and day 7 in a Connor study, in my opinion, may not necessarily support a fibrinolytic reaction. We know that many factors play a key role in changing the sensitivity and specificity of this testing, such as inflammatory conditions, elderly patient, or previous VTE. Now, Sergio mentioned that it's always better to join the US study to confirm a DVT. I think that everybody is doing ultrasound, and if you see, of course, we do not perform D-dimer on all our patients when performing sclerotherapy. I don't know if you do, but I don't. But I think that the ultrasound is probably the tool that you need to use to see if you see any signs of thrombolytic reaction. Now, it is interesting to see also that the concentration and the volume is affecting the pharmacokinetics and pharmacodynamics results. Now, there are few esophageal varices study with STS showing that they may be activation of blood coagulation, but we have to keep in mind that the patient affected with that kind of varices do have pulmonary or chronic liver disease. And Jacobson said that it is confusing because most of those patients do have abnormal coagulation markers at baseline. Now, Andrew in his talk shown results of RCTs. Now in the literature, there are 16 RCTs comparing different modalities for treating CVD. Now there's only 6 that are comparing the thermal ablation with ultrasound-guided foam sclerotherapy and surgery. And foam sclerotherapy is equally safe and effective, as Andrew said, and the most cost-effective technique and less recovery time. But redo treatment is more frequent related to recurrency, as Andrew stated. Now, Carol and all confirmed that 10-year technical recurrency may be higher with foam sclerotherapy, but it's not significant. And according to Meissner, the data in the comparative studies of different modalities are occasionally conflicting, and there's not appear to be substantial differences. Now, we realized that in all the studies, the protocol for ultrasound foam sclerotherapy was not standardized. So if we take the recommendation of Andrew, maybe to do more RCTs, now, first, I think we do have to have a standardized foam sclerotherapy protocol. Otherwise, I don't think it means much. Now, if I want to leave you with a very simple take-home message, I would say that sclerotherapy remains a great treatment as long as risks and benefits are well understood. Its popularity varies according to socioeconomic populations, health systems, and third-party reimbursement. Although there may not be a direct connection with sclerotherapy in COVID-19, which I'm not sure that I'm convinced of that, one needs to recognize when patients do have some high risk. Now, I do not, at this moment, take any new patients that I do not know the history. We do screen the patient on the phone before they take their appointment to make sure, of course, they were not tested positive, or they were not in contact with someone that has been tested positive. Now, we have to remember one thing here. Sclerotherapy is an elective procedure. So why put our patient at risk? We can wait. I mean, there's no problem to just postpone. And plus, it's summertime right now. So I think that even sclerotherapy, a lot of physicians are not performing sclerotherapy in summertime, especially in Canada, we do. So for me, I normally treat, I would say, treat patients that you know well, recognize high-risk patients that need prophylaxis, and make sure that you use appropriate individual dosage regimens. I don't believe that using a low concentration and a higher volume is the way to go. I think you should use a higher concentration and low volume. And if you want to be safer and be cautious, you may want to spread your treatment in several sessions in order to optimize clinical outcomes. Now, I concur with Andrew's conclusion and as well as Sergio. I mean, I think everybody will say that knowledge and training are the key to success. Know when to say no if you are not proficient in the technique. Now, I tried to make a very simple conclusion to this webinar, saying that the sclerotherapy has low rate of complication, especially for major complications. And I encourage everyone who would like to start doing sclerotherapy to really do it, but of course, not without exceptional training.
Thank you, Pauline.
Thank you very much.
Thank you. And now we conclude with the introduction of the one who gave the name to the methods. I don't know if introduce him like a mentor, like a family member. I will just introduce him as Lorenzo because we all know him. Lorenzo.
So, dear all, thank you for having me involved in this fantastic educational initiative. Thank you, Sergio and Andrew, for your excellent presentation. Here my 5 take-home messages are: 1. Sclerotherapy is extremely safe. 2. In a COVID time, it is possibly even safer than more invasive venous procedure. 3. Foam must be produced in a standardized way. 4. Foam is a competitive water technique in patient quality of life improvement. And 5. All the previous points are possible only in expert hand. So, training and educational initiatives like this one are fundamental. Thank you, and I hope to see you all as soon as possible a person. Thank you.
Thank you so much, Lorenzo. And now I conclude with other persons I consider family. So Oscar, if you want to have some closing remark, and then Willie.
Okay, thank you. As said, sclerotherapy is practiced whenever, particularly in Latin American, where I'm honored to say there is a spectacular technical expertise. I congratulate all the colleagues who have provided so valid insights today, showing the safety and the excellent performance of sclerotherapy, as long as in properly training hands, you know how they are, to me, medical education is. So once again, congratulations.
Thank you, Oscar. Willie, your final remarks?
Yep. Thank you, everybody. Good morning, good afternoon, and good evening. That's it. We're on time. We're out of time.
This is the reason why I like you so much. So let me then move. You are like even faster than me preparing the next slides. So very good. So let's say just goodbye to next Sunday. Next Sunday we will talk about advanced chronic venous disease with two huge figures, Professor O'Donnell and Professor Marston, and huge continental experts. Once again, deeply thank to all the ones who have made this possible. And once again, deeply thank to the Roger Taylor of Sclerotherapy, Professor Bradbury, also for the time it will take to answer to the questions, as I will do to all the ones we haven't answered now. So we will look at all the ones you wrote over there. Deeply thank to all the ones involved in this humanitarian not-for-profit initiatives dedicated indeed to Food for Veins and Veins for Food. Thank you, and see you next Sunday. See you, bye.
Bye, 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 bye.
Bye, bye.
Bye, Lorenzo, bye.
Thank you,
Bye,
bye.
everybody.
Bye,
It was a
Pauli.
great pleasure. See you soon. Stay safe.
Bye,
Goodbye.
Andrew. Bye, Shani. Bye, Carlos.
Bye-bye. Ciao, Carcito.
Bye,
Good to
everybody.
see you.